Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Megan Deck, a cardiac anesthesiologist working in Winnipeg at the University of Manitoba, discusses an approach to pulmonary hypertension for the non-cardiac anesthesiologist. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Good morning, everybody. It's nice to be back virtually. I'm Megan. I had done my residency here, and now I'm in Winnipeg. The talk that I'm giving today is called Under Pressure, an approach to pulmonary hypertension and right heart failure for non-cardiac anesthesiologists. The objectives of this talk are to review the pathophysiology and classification of pulmonary hypertension, describe perioperative optimization strategies for patients with pulmonary hypertension undergoing non-cardiac surgery, and to develop an approach to the management of a pulmonary hypertensive crisis and acute right heart failure. And this is a very practical talk, so hopefully you guys will glean something from it. As Henry alluded to, this talk was born out of a problem-based learning discussion that I was asked to facilitate at CAS this past June. So while I recognize that this group is too large and virtual to allow for an interactive discussion, I'd like to weave a real case throughout the presentation in order to provide some relevance. So in the true Royal College format, this is a real case. You're asked to care for a 57-year-old male with a new diagnosis of papillary thyroid cancer who is scheduled for an urgent total thyroidectomy. The patient has a long-standing history of idiopathic pulmonary arterial hypertension. How would you assess this patient? So I just want you to keep this in mind as we kind of progress through our discussion. So just for some background, pulmonary hypertension is a multifactorial group of disorders resulting in an elevation in mean pulmonary arterial pressure. The prevalence of pulmonary hypertension is increasing with an aging population and improved survival of targeted therapies, and many of these patients will require non-cardiac surgery. In a study of 17 million hospitalizations for major non-cardiac surgery in the United States from 2004 to 2014, perioperative major adverse cardiac events were fourfold higher in patients with a diagnosis of pulmonary hypertension. After adjustment for demographics, clinical comorbidities, and other surgical subtypes, pulmonary hypertension was associated with a 43% increase in the odds of a composite of death, MI, and stroke, and nearly a twofold higher risk of cardiogenic shock and cardiac arrest. Hence, this is becoming an increasingly big deal for anesthesiologists like you and I who will encounter these patients. So despite the rising prevalence of pulmonary hypertension, there's been little guidance regarding the perioperative management of these patients. And as such, the AHA published this scientific statement in 2023 to provide clinical guidance for the evaluation and management of pulmonary hypertension in patients undergoing non-cardiac surgery. The statement advocates for a multi-step process focused on the following. Number one, the classification of pulmonary hypertension group to underline and define the pathophysiology. Number two, perioperative risk assessment to guide surgical decision-making. Number three, pulmonary hypertension optimization before surgery to reduce perioperative risk. Number four, intraoperative management of pulmonary hypertension to avoid RV dysfunction and maintain cardiac output. And number five, postoperative management of pulmonary hypertension to ensure recovery. And it's this process that I'll use as a framework to facilitate the rest of this discussion. So before we can define pulmonary hypertension or classify it, we need to be able to define it. The definition of pulmonary hypertension that I was taught in medical school was a mean PA pressure of greater than or equal to 25 millimeters of mercury at rest. However, it turns out that this was an arbitrary threshold that was conservatively chosen to prevent overdiagnosis and treatment. Since that time, multiple studies have suggested that a mean PA pressure of greater than 20 is associated with excessive morbidity and mortality. And so in an effort to facilitate early diagnosis in high-risk patients, a revised definition was proposed in 2018. As such, pulmonary hypertension is now defined as a mean PA pressure of greater than 20 millimeters of mercury at rest, as measured by right heart catheterization. This is 2 standard deviations above the mean PA pressure of a normal healthy patient at rest, which is 14. It's also essential to include PVR and pulmonary artery wedge pressure to elucidate the etiology of pulmonary hypertension from a hemodynamic standpoint. So pulmonary hypertension can be classified both hemodynamically and clinically. In the hemodynamic classification of pulmonary hypertension, pulmonary vascular resistance and pulmonary artery wedge pressure are used to differentiate between so-called precapillary, postcapillary, and mixed pulmonary hypertension. Precapillary pulmonary hypertension refers to elevated mean PA pressure secondary to isolated pulmonary vascular disease, whereas postcapillary pulmonary hypertension refers to pulmonary hypertension secondary to isolated left heart disease. The picture can also be mixed in the context of both pulmonary vascular and left heart pathologies. In precapillary pulmonary hypertension, PVR will be elevated while left atrial pressure or pulmonary artery wedge pressure will be low. And in post-capillary pulmonary hypertension, the inverse will be seen. In most cases of isolated post-capillary pulmonary hypertension, the degree of elevation in mean PA pressure is proportional to the elevation in pulmonary artery wedge pressure. However, in some patients, the elevation in mean PA pressure is out of proportion. In this case, calculation of the transpulmonary gradient, which is the difference between the mean PA pressure and the wedge pressure, can be useful in determining the contribution of PVR and potential utility of pulmonary vasodilators. The clinical classification of pulmonary hypertension has evolved over the years from the 1973 World Health Organization Symposium to the 2018 World Symposium on Pulmonary Hypertension. The clinical classification categorizes conditions associated with pulmonary hypertension based on similar pathophysiologic mechanisms, presentations, hemodynamic characteristics, and therapeutic management. So group 1 pulmonary hypertension refers to pulmonary arterial hypertension. Group 2 is associated with left heart disease and is by far the most common that we'll encounter. Group 3 is associated with lung disease and or hypoxia. Group 4 associated with pulmonary artery obstruction, such as chronic thromboembolic pulmonary hypertension. And group 5 is kind of a grab bag associated with unclear or multifactorial mechanisms. It's important to recognize that the clinical classification system covers a spectrum of different diseases that can cause pulmonary hypertension, and many patients may cross these groups with multiple contributors to their disease. And this table here kind of summarizes both the hemodynamic parameters and associated clinical groups in the classification of pulmonary hypertension. And as you can see, there is quite a bit of overlap. So the next component of the framework that we'll address is kind of the perioperative risk assessment. As per the AHA statement, factors influencing perioperative risk can be classified according to patient and procedural aspects. Patient-related factors include pulmonary arterial hypertension with high-risk criteria, evidence of RV dysfunction, obstructive sleep apnea, a low exercise capacity, as well as an ASA score greater than or equal to 2. While procedure-related factors include emergency surgery, intermediate high-risk surgery, the intraoperative need for vasopressors, and surgery lasting more than 3 hours. The overall perioperative risk assessment should follow the usual chart review, history, physical, and investigation format, and is essentially aimed at assessing pulmonary arterial hypertension risk, isolated pulmonary risk, cardiac risk, and the risk associated with coexisting systemic disorders. There are multiple risk tools used to assess these risks based on the AHA statement, and these are outlined, I know, very small, but in the table adjacent here. So when we're seeing these patients and we're trying to elucidate a history, what exactly are we looking for? Essentially, we're trying to assess their current functional capacity and exercise tolerance, as a worsening NYHA functional class, as well as a worsening 6-minute walk test, both portend a 4-fold increase in perioperative complications. Symptoms of pulmonary hypertension are mainly linked to RV dysfunction and typically associated with exercise in the earlier course of the disease, with the cardinal symptom being dyspnea on progressively less exertion. Cardiac symptoms assessed should include exertional dyspnea, P&D or orthopnea, palpitations, weight gain or fluid retention, and syncope. Additional questioning should center around the presence of hemoptysis and symptoms resulting from pulmonary artery enlargement, which could include hoarseness, angina, as well as recurrent pulmonary infections. Physical exam is important in assessing both the severity and underlying cause of the pulmonary hypertension. The examination can kind of be broken up into 4 pillars. The first being assessing for signs of pulmonary hypertension, which might include cyanosis, the systolic murmur of tricuspid regurgitation, or diastolic murmur of pulmonary regurgitation. Signs of backward RV failure, which may be elevated JBP, abdominal distension, hepatomegaly, and peripheral edema. Signs of forward RV failure, which could include cyanosis, pallor, or cool extremities. And then other signs pointing to an underlying etiology of the pulmonary hypertension. In terms of investigations, basic lab investigations should include a CBC to assess for polycythemia as a surrogate for chronic hypoxemia, in addition to our normal perioperative hemoglobin evaluation. Creatinine and liver function tests to assess for congestive nephropathy or hepatopathy as a sequelae of RV failure. An ABG should be done to assess the PaO2, which is usually low normal, but may be severely low and indicative of intracardiac or extracardiac shunts, as well as a PaCO2 to look for chronic CO2 retention. A BMP would also be useful to assess for right or left heart failure. Additional investigations could include the following. The ECG can deliver prognostic information, detect arrhythmias, as well as signs of left heart dysfunction. In adults with a clinical suspicion of pulmonary hypertension, right axis deviation has a high predictive value for pulmonary hypertension. A normal ECG does not exclude the presence of pulmonary hypertension, but a normal ECG in combination with normal biomarkers, such as a normal BNP, is associated with a low likelihood of pulmonary hypertension. The chest X-ray in most patients with pulmonary hypertension is probably abnormal. However, a normal chest X-ray does not necessarily exclude the diagnosis. In terms of a CT chest, signs of pulmonary hypertension could include a large PA diameter, a PA to aorta ratio greater than 0.9, as well as enlarged right heart chambers. Additionally, on the CT, we can look for parenchymal disease, the presence of effusions that may warrant perioperative drainage to optimize FRC, as well as any other underlying cardiac pathology. PFTs are also useful to elucidate the etiology of the pulmonary hypertension. And of note, a reduced DLCO, less than 32%, may signify advanced disease and warrant further examination of RV function. Lastly, and probably what we're most concerned about, is the echo. This provides comprehensive information on right and left heart morphology, RV and LV function, as well as valvular abnormalities, and gives us estimates of hemodynamic parameters. Of note, echo is a valuable tool to detect the cause of pulmonary hypertension. However, we need to recall that echo alone is insufficient to confirm the diagnosis, which requires a right heart catheterization. So when we receive the echo report in PAC, what specific things should we pay attention to? These include signs of RV pressure volume overload, as well as the RV systolic function. Signs of RV pressure volume overload can include enlarged right atrial or right ventricular chambers, an RV to LV ratio of greater than 1, or a dilated IVC. Signs of decreased RV systolic function could include an RV fractional area change of less than 35%, a TAPSE or a tricuspid annular plane systolic excursion of less than 1.8, and an S prime, which is measured at the mitral annulus, tricuspid annulus of less than 9.5 centimeters. TR velocity can also be used to assess RV systolic function, as well as a surrogate to assess mean PA pressure. We're commonly accustomed to looking at the right ventricular systolic pressure, or RVSP, which is a surrogate for pulmonary artery systolic pressure in the absence of RVOT obstruction. Pulmonary artery systolic pressure is calculated by the modified Bernoulli equation, which is 4 times the tricuspid velocity maximum jet squared plus the right atrial pressure. A normal PASP is less than 35, and a PASP of greater than 60 is suggestive of pulmonary hypertension. However, there are several limitations to the PASP calculation. Firstly, there's error in measuring the TR maximum jet. This is due to eccentric jets or poor Doppler alignment. The TR velocity is squared and multiplied by 4, so if there are small errors in this absolute measurement, it can result in significant changes to the estimate. And in the absence of a central venous catheter, there's error in measuring the IVC diameter. As well, there's poor correlation between TR velocity in severe cases, as well as the RV systolic function. As such, the ESC, or European Society of Cardiology, endorses a measurement of TR velocity jet alone. And in this case, a TR maximum velocity of less than 2.8 meters per second suggests a low probability of pulmonary hypertension, whereas a TR maximum velocity of greater than 3.4 meters per second suggests that pulmonary hypertension probability is high. Lastly, and perhaps most importantly, is to review the right heart cath. The right heart cath is a gold standard for diagnosing and classifying pulmonary hypertension, allowing for measurement of hemodynamic variables as well as vasoreactivity testing to assess response to therapy. Vasoreactivity testing is used to identify vasoresponders who may be candidates for treatment with high-dose calcium channel blockers. In this test, inhaled nitric oxide as well as inhaled iloprost are used and recommended test compounds and performed at the time of right heart cath. A positive acute response is a reduction in mean PA pressure greater than or equal to 10 millimeters of mercury to reach an absolute value of less than 40, with either an increased or unchanged cardiac output. And this table on the side of the slide here outlines the common measured as well as calculated parameters that you'll see on the right heart cath report. So in terms of preoperative optimization, 2 to 4 weeks before surgery is a reasonable time frame for a patient to be seen to determine which components of risk stratification will be relevant at the time of surgery. In addition to risk stratification and disease optimization, perioperative medication management is a cornerstone of seeing these patients. If targeted pulmonary hypertensive therapies are planned to be initiated before surgery, 6 to 12 weeks is usually adequate for allowing maximal therapeutic effect on the pulmonary vasculature. In addition, common medications these patients will be on will include the following: specific pulmonary hypertensive therapies such as calcium channel blockers, endothelin receptor antagonists, phosphodiesterase 5 inhibitors, prostacyclin analogs, either oral or inhaled, prostacyclin receptor agonists, as well as soluble guanylate cyclase stimulators. These therapies should all be continued perioperatively to avoid rebound pulmonary hypertension. Additionally, these patients often present on diuretics, and these should be continued preoperatively and on the day of the OR to avoid potential precipitation of acute decompensated heart failure. Lastly, patients with chronic thromboembolic pulmonary hypertension will often be on anticoagulants, and these may warrant perioperative bridging. So just briefly, I'll bring you back to this case, again, a real one that we saw in Winnipeg. So more information on this man. He had been on home oxygen for a year. He was showing clinical signs and symptoms of right ventricular failure. He was recently admitted to hospital in decompensated congestive heart failure. His past medical history was significant for obstructive sleep apnea, for which he was compliant with CPAP, hypertension, and type 2 diabetes. He had a 10-pack year smoking history, but quit 20 years ago. His current medications included bosentan, sildenafil, spironolactone, and sitagliptin. He was previously a heavy equipment operator, but had been on disability leave for the past year due to worsening dyspnea. On physical exam, he had a reassuring airway with a Mallampati score of 1. There were no obstructive symptoms or signs related to his thyroid mass. His vitals were a blood pressure of 98/69, a heart rate of 84, and an oxygen saturation of 100% on 4 liters per minute of oxygen. His auscultation of his chest was clear. He had normal heart sounds with a moderate diastolic murmur, which was loudest at the left sternal border. He had excellent peripheral veins and arterial pulses and mild peripheral edema, but was pitting to the knees. In terms of investigations, he had a right heart catheterization that revealed pulmonary hypertension with a PVR of 7 Woods units and no obstructive coronary disease. He had a transthoracic echo that demonstrated a normal size LV with an EF of 60%. His RV was severely dilated with moderately reduced systolic function and severe tricuspid regurgitation with an RVSP of 103. So again, keep this in mind, but think about how you might provide an anesthetic for this patient. So in terms of intraoperative management, we need to consider what monitors might be necessary in these cases. Standard CAS monitors with the addition of invasive blood pressure monitoring should be used in all of these patients. Consideration should also be given to a central venous catheter to facilitate real-time monitoring of CVP as well as vasoactive drug administration. Of note, the isolated CVP value is not necessarily predictive of preload. However, dynamic changes in the RV filling pressure, new onset right heart failure, or worsening tricuspid regurgitation can be detected through examination of the CVP waveform. One could also consider the placement of a pulmonary artery catheter in such cases, as this provides a dynamic number that will inform therapy. However, the benefit of pulmonary artery catheter use has not been demonstrated in non-cardiac surgery, and unless you're very familiar with their insertion and interpretation, I would advise it best be avoided. Lastly, for those trained in its use, TE is a valuable tool for assessing dynamic biventricular function, as well as assessing for valvular abnormalities intraoperatively. In terms of induction agent choice, while there are no comparative studies to suggest the superiority of one induction agent over another, core hemodynamic principles, including the avoidance of hypotension and maintenance of contractility, should be considered. Etomidate is a reasonable option as it has minimal effect on systemic and pulmonary vascular resistance, as well as heart rate and contractility. It remains controversial to some extent given its risk of adrenal cortical suppression, and as such, prolonged infusions or repeat doses should be avoided. Ketamine is associated with an increased risk in pulmonary vascular resistance in adults and might be avoided if PVR monitoring or pulmonary vasodilators are not concomitantly used. However, low doses of ketamine would not be contraindicated in this case. Propofol can directly or indirectly adversely affect RV contractility through its propensity to cause hypotension as well as inherent myocardial depression, and so low and judicious doses of this should be used. Opioids, when administered alone, have a minimal effect on the pulmonary circulation and reduce response to sympathetic stimulation, but they may induce unfavorable bradycardia in larger doses. Pre-medication with benzodiazepines and opioids should be performed judiciously, with their co-administration may cause an acute increase in PA pressure, attributable to hypoxia, hypercarbia as a result of hypoventilation. Consideration may also be given to the performance of a rapid sequence induction to minimize periods of hypoventilation, hypercarbia, and hypoxia versus the benefits of a titrated, hemodynamically stable induction. Additionally, any inhalational agent can be used for anesthetic maintenance in these cases, except for nitrous oxide because of its effect on increasing PVR. Now, before we delve into the specifics of intraoperative hemodynamic management, I think it's pertinent to review some of the basic physiology and pathophysiology of right heart failure. The RV differs greatly from the LV. In contrast to the ellipsoidal LV, the RV is triangular from side to side, crescent-shaped in cross-section, and wraps around the LV. The RV has a larger volume than the LV, hence its ejection fraction, 45 to 60%, is less than the LV. In contrast to the circumferential, longitudinal, and radial contraction of the LV, RV contraction occurs with a peristaltic-like movement beginning at the base and progressing toward the outflow tract. The most important movements are the inward movement of the free wall, contraction of the longitudinal fibers moving the tricuspid annulus toward the apex, as well as LV free wall contraction. Coronary perfusion to the RV occurs in systole and diastole, compared with the primary diastolic flow of the LV, making the RV very dependent on systolic blood pressure and relatively intolerant to systemic hypotension. This image here shows the relationship between coronary blood flow and aortic pressure. Furthermore, and pivotal to the understanding of RV function under normal and abnormal conditions is the concept of ventricular interdependence. Ventricular interdependence suggests that forces are transmitted from one ventricle to the other through the myocardium and pericardium. Thus, the higher intracavitary pressure of the LV is transmitted through the septum to the RV. The pressure difference between these two chambers is termed the transeptal gradient. The RV's geometry is dependent on the position of the interventricular septum, which normally bulges into the RV, creating a scaffold against which the RV free wall can contract. While 4 to 10% of LV systolic function depends on the RV through ventricular interdependence, 20 to 40% of the RV systolic function depends on the LV and the position of the septum. So knowing that, why does the RV fail in the context of pulmonary hypertension? The RV fails due to pressure overload with progressive increases in RV afterload resulting in RV to PA uncoupling. This is the process whereby RV contractility cannot increase to match increases in afterload, resulting in right heart failure. In the figure on the left, we can see how an increase in RVSP causes RV dilation and flattening of the interventricular septum. The septal shift distorts the normal geometry of the RV, which will result in worsening TR and volume overload and impair RV free wall contraction. Impaired RV systolic function will result in a decrease in RV cardiac output and subsequent decrease in LV preload, which will then decrease LV cardiac output. This will result in systemic hypotension and, given the RV's dependence on both systolic and diastolic blood pressure, a decrease in coronary perfusion. Decreased coronary perfusion in the context of elevated wall stress from volume and pressure overload will precipitate worsening ischemia, and the downward spiral will continue to ensue. As the RV begins to fail, LV systolic pressure will drop, resulting in a further reduction in the transseptal gradient, worsening septal flattening, and further RV systolic dysfunction. While RV to PA uncoupling is the natural consequence of progressive increases in RV afterload, this can be precipitated intraoperatively by a number of factors, including hypoxia, hypercarbia, acidosis, hypothermia, shivering, and the use of alpha agonists. Importantly, alterations in FRC represent a crucial factor influencing PVR. The figure on the screen shows the relationship between PVR and lung volume and is perhaps one of my favorite physiologic figures, mostly because it's really easy to draw. The figure illustrates that PVR is lowest at FRC and highest at either residual volume or total lung capacity. As such, anything that increases lung volume, which could include atelectasis, endobronchial intubations, effusions, inadequate PEEP, pneumothorax, or consolidation, will increase PVR, as will excessive lung volume, such as too much PEEP, high tidal volumes, or air trapping. Acute RV shock also yields a so-called double hit phenomenon. Recall that organ perfusion pressure is equal to the MAP minus the CVP. Because of the high CVP in right-sided heart dysfunction, organ perfusion pressure is reduced more in RV shock to a greater degree than it is in LV shock for the same mean arterial pressure. This hypotension, coupled with an increase in CVP, leads to the rapid development of vital organ ischemia, with hepatic failure, renal failure, and bowel ischemia being common complications. So, recognizing this pathophysiology, what are our intraoperative hemodynamic goals for our patient with potential pulmonary hypertension and RV failure? Now, I may be a bit biased given where I'm currently working, but this paper was published by a couple of intensivists and cardiac anesthesiologists here in Winnipeg and provides a really great overview of the basic management strategies for these patients. Above all, the goal is to maintain RV coronary perfusion and, as such, the transseptal gradient. So, first thing we can optimize is cardiac rate and rhythm. A dysfunctional RV should be maintained in normal sinus rhythm. Atrial fibrillation and heart blocks are not well tolerated, and so early cardioversion or defibrillation is indicated. Because acute RV failure is associated with tricuspid regurgitation, higher heart rates, usually greater than 80 beats per minute, are generally indicated, as this might reduce RV distension and TR and thus increase cardiac output. Secondly, we need to optimize RV filling. A tenuous RV is intolerant to both over and underfilling. Overfilling will stretch the tricuspid valve annulus, increase tricuspid regurgitation, aggravate organ congestion, decrease the transseptal gradient, and thus cardiac output. In contrast, underfilling will decrease RV cardiac output, MAP, and subsequently CPP, resulting in worsening ischemia. Common determinants of volume responsiveness, such as CVP and PPV, cannot be relied upon due to the beat-to-beat variability in RV stroke volume, which will lead to variation that is not necessarily related to volume status. So we advocate for judicious volume administration with small aliquots of maybe 250 mils, or even a passive leg raise to assess for fluid responsiveness. Fluid responsiveness would be indicated by a modest increase in CVP, maybe 2 to 5 millimeters of mercury, as long as it remains less than 20, together with a significant improvement in systemic perfusion, which could be measured by cardiac output, mean arterial pressure, or other clinical findings. If only the CVP increases, there's little evidence of improved perfusion, and deleterious RV distension may occur. Thirdly, we must maintain systemic vascular resistance and coronary perfusion at all times. This is the most important initial treatment strategy in acute RV shock, as it promotes coronary perfusion and increases LV systolic pressure to maintain the transeptal gradient. Pharmacologic options include vasopressin and norepinephrine. Vasopressin is favorable as it has no effect on pulmonary vascular resistance. However, while the alpha agonism of norepinephrine will affect the PVR to some degree, it also has an inotropic benefit that's often required. As such, a combination approach with both of these agents is often necessary. Additionally, we of course need to support RV contractility. Inotropic choice is either a beta agonist such as dobutamine or epinephrine, or a phosphodiesterase 3 inhibitor such as milrinone. While these are both great inotropes, their benefit can be lost with their propensity to reduce systemic vascular resistance. This is especially true with milrinone. In severe RV shock, a combination therapy with low-dose milrinone as well as low-dose dobutamine might be the best choice for increasing contractility with fewer side effects than any one drug alone. Reduced systemic vascular resistance and a possible reduction in BP can possibly be mitigated with the concomitant use of vasopressors such as norepinephrine and vasopressin, as we previously mentioned. Lastly, we must maintain low pulmonary vascular resistance through both non-pharmacologic and pharmacologic means. From a non-pharmacologic perspective, we want to avoid obvious precipitants of increased PVR, such as the hypoxia, hypercarbia, acidosis, and excessive sympathetic stimulation, as previously mentioned. Additionally, the ventilator should be adjusted to avoid over or under distension, the endotracheal tube positioned confirmed to avoid endobronchial intubation, and peak pressures kept less than 30 centimeters of water. Additionally, we might lean more toward paralyzing these patients to avoid ventilator dysynchrony. From a pharmacologic standpoint, intravenous vasodilators such as prostanoids, nitroglycerin, or calcium channel blockers have little role in the management of intraoperative or acute RV failure. These agents, although they might dilate the pulmonary vasculature, cause systemic hypotension, which will further worsen our RV function. IV agents also inhibit hypoxic pulmonary vasoconstriction and may potentially worsen VQ mismatch and hypoxia. Inhaled pulmonary vasodilators are preferred as they directly reduce PVR in well-ventilated lung regions and improve VQ matching by matching increasing flow to the ventilated areas with improved oxygenation. Inhaled nitric oxide is probably the first thing that we think of, as it's easy to use via either an OptiFlow nasal cannula or the anesthetic circuit. However, it is quite bulky, expensive, and does require toxicity monitoring if used over long periods of time. Inhaled milrinone is another option, as it portends less systemic hypotension than IV. It can be nebulized preoperatively or even given down the endotracheal tube in acute scenarios. Lastly, the short-term use of sildenafil may be helpful. This is a potent phosphodiesterase 5 inhibitor acting separately from the PDE3 inhibition of milrinone. It dissolves easily in a ml of sterile water, which could be done in the OR, and then given in the operating room sublingually to avoid any absorption issues with gut edema. It does cause some systemic vasodilation, but this can be easily offset with the use of other vasopressors. So here's kind of a helpful summary of the CROP goals for the intraoperative management of pulmonary hypertension and RV failure. Again, our goal is to increase contractility with either low-dose dobutamine, milrinone, or preferentially the combo of the two, to maintain a high normal heart rhythm, strictly in normal sinus rhythm, to maintain our afterload or systemic vascular resistance with vasopressors such as vasopressin or norepinephrine, to maintain our preload and specifically avoid any acute overfilling or underfilling, and of course, to decrease our pulmonary vascular resistance through both physiologic and pharmacologic means. So just to kind of end things off, back to our case, midway through the procedure, this patient's ventilator alarms with increased airway pressures and the patient coughs. Subsequent to this, the CVP rises from 15 to 22, and the arterial line tracing appears dampened with a reading of 68/50. What do you think is going on, and how would you manage? So this patient, likely due to the ventilator dysynchrony, acutely increased his PVR and is now entering that spiral of a pulmonary hypertensive crisis. So again, our primary goals in this case are to restore the transseptal gradient by increasing our systemic vascular resistance and decreasing our PVR. So kind of a helpful algorithm to go through is what I have listed here. So the first thing you do is increase the systemic vascular resistance. So this could be done acutely through bolusing either low dose or even higher doses of vasopressin or norepinephrine and decreasing vasodilating anesthetic drugs. Of course, you can increase the infusions of these medications after, but you'll need something acute to temporize in the meantime. Additionally, we want to increase contractility. So boluses of epinephrine, ideally kind of in the 10 up to 100 mic range, depending on how sick your patient is, could be used. Importantly, I would avoid IV boluses of milrinone in this situation, as they certainly do cause systemic hypotension, and that will not help you in this situation. We also want to decrease PVR, so non-pharmacologically, we can quickly flip the patient onto 100% oxygen, paralyze them to avoid any further ventilator dysynchrony, increase their minute ventilation, leaning a little bit more toward hyperventilation, and aggressively normalizing their pH with bicarb boluses if it is abnormal. Pharmacologically, in this case, we could initially try some transtracheal milrinone at a dose of 2.5 to 5 milligrams as we're setting up our inhaled nitric oxide for further pulmonary vasodilation. We could consider optimizing our preload with either a passive leg raise or a small 250 mil IV bolus to see if that helps. But again, I'd be very cautious with this, and ideally do it under echo guidance if you have the skill. And then optimize our rate and rhythm if the patient was in any arrhythmia, early cardioversion, and if you have the ability to transcutaneously pace or up their heart rate pharmacologically, you could do that. And then, of course, correcting the inciting trigger. So in terms of postoperative management, the tenets are pretty self-explanatory. After routine surgery without any untoward intraoperative events, most patients could be admitted to PACU with close monitoring and probably a prolonged stay just to make sure that they're doing all right. ICU admission should be considered based on procedural complexity and intraoperative events. But certainly in the case of the patient that I presented with extremely high pulmonary hypertension or pulmonary artery pressures, I would elect to just have him electively admitted to ICU after the case. Optimal pain control is pivotal in these patients, as increases in PVR may lead to acute decompensation. However, opioids should be administered cautiously and judiciously to avoid harmful hypoventilation, which could also further increase PVR. And additionally, usual hemodynamic goals like the ones we had in the OR should be kept in mind and maintained as they were intraoperatively.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.